Our next speaker is Dr. Mazzotta, who has a large number of papers published regarding morphology after college and cross-linking. He's going to discuss accelerated cross-linking and pixl.
So the presentation contains three basic concepts of common findings with conventional cross-linking. And the classical accelerated cross-linking with the standard energy dose of 7.2 joule with continuous light or pulsed light treatment, and the pixl with variable energy doses focal pattern cross-linking according to corneal topography. As you know, this was the first study in confocal microscopy that demonstrated in vivo in humans for the first time the keratocyte apoptosis after a conventional corneal cross-linking. That is one of the major findings after this treatment. As you know, keratocytes are populated gradually in the stroma, and we have also a slight increase in density of the extracellular matrix. The increase in density of extracellular matrix with the photopolymerization with the collagen and the formations of dark microstriate bands or reflections is one of the leading elements that increase biomechanical stability of the cornea. We have a high molecular weight collagen and more resistant to heat, more resistant to enzymatic digestants, and this is the basic of leading to increased biomechanical stability, but also to functional response that we recorded after standard cross-linking. As you know, the concept of the apoptosis was important also to define not only with the Brownian microscopy, but also with the lower penetration with the transepithelial treatments that demonstrated a low efficacy compared with the standard treatment. Also, we have defined which are the risk factors for AIDS development of this therapy, but you need to distinguish between the real AIDS and the increased density of the stroma that is desirable after this treatment. If you don't see anything, maybe you don't have effect, but you need to distinguish between real AIDS and a slight increase in density of extracellular matrix with regular presence of keratocytes in the stroma. As you know, the intraoperative reduction of the corneal thickness was very dangerous with dextran solution. So I was asked for the first time to express an opinion for the Vibes Rapid that Avedro introduced in our clinical practice, avoiding corneal dehydration intraoperatively and avoiding complications. These are the first image of accelerated cross-linking with continuous and pulsed light treatment, 30 milliwatt, 4 minutes or 8 minutes, 1 second on and 1 second off. What is common with the conventional procedures? The common findings, it is different the density from the conventional, because we use 7.2 joule and not 5.4. The 7.2 joule increased the density of the stroma, but what we have different also is the penetration and the depth of the penetration compared with the standard. In the standard we had 300 microns of penetration. With accelerated cross-link we have 150, 170 penetration with continuous light, 4 minutes, 30 milliwatt, and 7.2 joule. As you can see, this is common. We have in the 6 months the complete regeneration of nervous fibers that is similar to conventional procedure. Also, we have a repopulation of the anterior stroma and the intermediate stroma that is common with conventional. And also, you can see that common conventional procedure is the presence of the microbands or striate reflections that are these microbands that you can see also in standard treatment, and is one of the elements of the cross-linking. It was safe, obviously. Also, the accelerated cross-linking demonstrated its safety for corneal endothelium. This is the article that I have recently published in Eye, that demonstrated the different penetration in continuous light and pulsed light treatments. As you can see, in the continuous light, we achieve that at about 170 microns on average. And if we use the pulsed light, we go deeper at about 250 microns of depth. Again, this is an overview. You can see the conventional treatment with 347, a transepithelial apoptosis, a continuous light accelerated cross-linking, and as you can see, a pulsed light treatment with the depth of 247 microns. So, we choose today to work definitively with the pulsed light and not with continuous one. We have published recently the 1-year follow-up comparing two population patients treated by accelerated cross-link with continuous and pulsed, and we have better results in a pulsed light treatment with an increase of visual acuity, both for uncorrected distance visual acuity and corrected distance visual acuity in pulsed light treatment compared with the continuous light treatment. These are the different depths recorded with different instruments. You can see the different penetration of the two treatment modalities. Now I want to speak about the focal pattern and cross-linking, topographic guided cross-linking. As you can see, this is a treatment planning. We work with the NARC step planning, using measured energy in the steepest area and the low energy in the flattest area. And as you can see, this is the post-operative aspect. It's a good aspect of the cone after the removal of the contact lens. This is the pentacam difference map. You can see the flattening in the apex cone area and the steepening in the superior part. This is essential with an improved visual acuity of the patient. As you can see at the Visante, you can find a double demarcation line according to two different energies that we use. And this is clearly shown. This is a different energy that we plan and the different demarcation line according to different curvature. As you can see, we have a great increase in density of extracellular mass. It is the leading effect that we need to have a compaction of the collagen and to have the flattening effect that we need. As you can see also the 10 joule, you can see the difference between the, compared with the standard treatment, we use 10 joule on if we use, this is the demarcation line. And a new concept is that when we increase the energy dose, we go deeper. So when we use 5.4 or 7.2, the depth of the treatment is dependent from exposure time, mainly. While if we increase the energy at 10 joule, 15 joule, we go deeper also for the energy that we use. This was a new finding of this study. The endothelium was spared, so this was safe for the endothelium. Look at these keratoconus. This was planned with 3 different energy according to different curvatures, 7.2, 10 joule, and in the steepest area, the apex, 50 joules. And you can see the clinical aspect of the cone after the removal of therapeutic contact lens. You can see a certain demarcation line also visible at the biomicroscopy. And you can see the flattening in the cone at 3rd month of observation, and the triple demarcation line according to different energy that we use. You can see we can find 3 different lines of penetration of the treatment according to different energies. So this was very interesting for us. another image of the very high intensity of the mastic with 15 joule of energy dose. This is a 10 joule treatment, and this is a demarcation line that you can see about 300 microns of penetration. That is very similar to the standard. So this is very important. The endothelium was safe. I will show you only the last case. This was a 4-month observation, and as you can see, there is a great flattening in the cone area and a steepening in the superior part, so a good impact, and double demarcation line, again with 2 different energies. This is the 2 energies and the double demarcation. I'm sure this is another demarcation line at about 300 microns, and the endothelial aspect that was normal. So now we are evaluating this technique in experimental setting, in vivo, early and late modification. The exposure times, the energy dose are essential in achieving a different penetration. We need to know, obviously, the long-term ectasia stabilization, so we need prospective studies. We need to understand if we will have some complication. Today we don't have complication, and we have a good functional response in a short-term follow-up. Thank you very much.
Have you followed the confocals over time? Is there a differential repopulation?
Yes. For strict time, I don't show the imaging. Yes, I have a repopulation just at 3rd month. I have here the imaging, so we don't have keratocyte damage like the standard treatment. So we have an increased density of the extracellular matrix, but just at 3rd month of observation, we have a decreasing of the density and increasing of the population.
Clinically, can you differentiate your areas of treatment when you're looking at the slit map?
No. The cornea is clear, very clear, with good clinical aspect. And patients are happy and they see better very, very, very fast. Thank you.
Thank you. Our final speaker, Dr. John Candelopoulos, has probably the most experience